fraction by echocardiogram. But as you'll see, whereas previously the classic myocarditis group by about 10 to 15 days, about 30% of children still had decreased ejection fraction. By that same period in the MISC group, nearly all had returned to normal ejection fraction, so normal function by their echocardiogram. In the vaccine-related myocarditis group, and this is just in our first 9 patients, decreased function, decreased ejection fraction was rare in about 2 of the 9 patients, so it was not nearly as common. And those patients had full resolution back to normal function within a few days. So now let's move to some of the longer-term outcomes. So what do we know about the pre-COVID era for outcomes? So first, we know that myocarditis presents a risk of sudden death in children and adolescents. In a paper published last year, it was noted that 5 to 10% of sudden death in adolescents and young adults was attributable to myocarditis. I want to make clear that's not saying that 5 to 10% of those with myocarditis are at risk for sudden death. It's saying that 5 to 10% of sudden death on autopsies were found to have myocarditis, usually not previously diagnosed. And it's findings like this that help inform the latest guidelines in the American Heart Association, American College of Cardiology. These were published in 2015, and their approach to myocarditis is that children, before returning to competitive sports for children and adults, should basically have a full cardiac evaluation to look for any evidence of decreased function, myocardial inflammation, or arrhythmias. Many kids have abnormalities on their MRI in myocarditis. I didn't show it here, but in the VAERS reports, about 72% who had an MRI had some inflammation or other findings consistent with myocarditis on the MRI. But it's unclear whether resolution of late gadolinium enhancement, and you'll see that come up later, should be required in MRI. This is still under research and trying to figure out the meaning of this. But the important thing to note also is that this recommendation from American Heart Association, American College of Cardiology, specifically mentions that it is independent of age, gender, and left ventricular function. So having normal function does not necessarily mean that you're out of the woods from a risk standpoint. So what are risk factors, though, for myocarditis outcomes? Again, in the pre-COVID era, and this paper was recently published, which had a good summary of factors and variables that can lead to a good outcome or poor outcome. So as it relates to vaccine-associated myocarditis, I put in a box some of their features which are very similar or might portend a good outcome. The first, chest pain and Class New York Heart Association 1 and 2. This is a very common presentation of vaccine-associated myocarditis. They're not presenting typically with some of the other features that you'd see that portend a bad outcome. Electrocardiogram. Many of the vaccine-associated myocarditis kids have ST elevation of their myocarditis, but other findings are rarer. Troponin, early rise and fast decline associated with a good outcome, and that is the typical story that we see with vaccine-associated myocarditis, although occasionally there can be some persistently abnormal levels. And then echocardiogram, preserved LV ejection fraction on onset or early improvement of that. That seems to be the typical finding with vaccine-associated myocarditis. And again, here we'll see cardiac magnetic resonance imaging. This is the area that we need to follow and see in these kids because presence of late gadolinium enhancement or persistence of this over time can be associated with a poor outcome. And as I mentioned on presentation, a fair number of those with vaccine-associated myocarditis did have some of these findings despite having all the other factors associated with a good outcome. What are some of the long-term outcomes pre-COVID myocarditis? This is a paper from 2004, so it is from a couple of decades ago, looking at myocarditis in children, and they broke these up into 3 groups and looked at them over about 14 years. Top group is the acute myocarditis group, second is borderline myocarditis, and third is groups that dilated cardiomyopathy that wasn't inflammatory, so not really an acute myocarditis picture. And it showed that those in the acute myocarditis actually did quite well over time. So, once you get over the acute phase, the long-term outcomes tended to be quite good in children. In adults, the picture is a little bit different. Again, this is an older study from 1995. The study was comparing immunosuppressive therapy for myocarditis and showed no difference in long-term outcomes. But the long-term outcomes in this group, and in total there were 111 patients with a mean age of 42 years. At about 5 years, cumulative mortality is about 50%. What do we know about the 3 to 6 month outcomes for multisystem inflammatory syndrome in children? This question came up earlier. So this is looking first just at ejection fraction, so the cardiac function, the red line being normal ejection fraction. And as you can see in that first blue box, a number of kids had an abnormal ejection fraction on presentation or during their lowest EF during the course of their illness. But by discharge, most had reached normal ejection fraction. And by 2 weeks, almost all had normal, with all having normal at 6 months. And this was in 50 children with a median age of about 8.5 years. What about the cardiac magnetic resonance imaging? So this is about 19 kids, and this group did follow-up MRIs, and they found no persistent cardiac changes in cardiac MR at follow-up. There have been some other reports here of some smaller changes, but it is quite rare in kids. Not shown here because I was asked to speak primarily on myocarditis, but this question did come up. Concerns about other factors. And there is a paper published out of the UK looking at some 6-month outcomes for kids with MIS. They had similar findings from some of the cardiac findings, but they also looked at some quality of life questions. And I will point out about 20 to 30% of children and their parents reported either mild or severe impairment on at least one scale, with the highest being an emotional scale, having some difficulties with the emotional level. There was no control group, so it's hard to determine how much of that was due to COVID versus just the COVID pandemic settings versus their own personal illness, but it is interesting to continue to follow. What do we know about COVID-19 vaccine-associated myocarditis in adolescents? We don't know a whole lot yet. This paper looking at 54 patients with a mean of 15 years, again, 92% male. This is looking really at about 1 month since vaccination for a mean of 35 days. About 13% still had persistent symptoms despite all of them having normal echocardiograms. 80% had normal EKGs, but about 20% obviously still had some abnormality. Troponin, when it was checked, was usually normal, although a few had borderline findings. And only 2 had MRI by this time at about 2 months and 2.5 months. Did show improvement in myocardial edema, but some persistence of late gadolinium enhancement. Vaccine Safety Data Link is also following up the cases that have been identified. They're doing chart review to look at their follow-up. As of earlier this month, they had done reviews for 47 cases, 37 of whom had at least 1 follow-up visit. And of those, some of them had a follow-up visit at least 3 months since their initial encounter. And we'll point out down the slide, any new or worsening symptoms present on about 20 to 50%, and this did vary by age. Troponin levels, EKG, and echocard often had some abnormalities, again, in about 20 to 50%. Echocardiograms were typically normal when they were performed. Only 1 MRI had been completed in this group to date. So I classified these groups as their current status, and these are not mutually exclusive groups, but by age, about 30% of those 12 to 17 have been given a status of recovered, meaning no medications, no exercise restrictions, no ongoing symptoms. About 50% of those in the 18 to 39 year age. CDC is also doing an investigation to investigate the long-term effects of myocarditis. And CDC is reaching out to patients who had been identified in VAERS case reports, and the purpose is to assess their functional status and clinical outcomes long-term. There's a 2-part component to the survey. First, contacting the patients themselves or their parents to assess functional status, clinical symptoms, quality of life, and other ongoing clinical needs. And then asking them to identify a healthcare provider that they're seeing, which is usually a cardiologist, to try to gather information on their cardiac health and functional status. So to date, about 680 patients have reached the 90 days post-myocarditis diagnosis. About 41% of these have received one phone call. About 60% of those have completed the survey. About 168 patients were able to identify, 132 of them were able to identify a cardiologist or healthcare provider. About 26 of them have completed the survey. So more data on this will be forthcoming. In summary, myocarditis is a rare but important adverse event following COVID-19 vaccination. And not all myocarditis is the same. There may be some similarities in presentation with some or in acute outcomes with others. So it's hard to do straight comparisons, although sometimes that's the best that we have. And we really need to see what the long-term outcomes for these kids will be. So far, the data for follow-up results is sparse, but ongoing follow-up is in progress. Thank you very much. Next, I'd like to thank Tom Chimbakor, John Su from the Vaccine Task Force, and Nikki Klein from Vaccine Safety Data Link for sharing some slides, Sam Butler from EPIC, and Matt Hall and Terry Thurman from Children's Hospital Association for sharing some very preliminary data. Thank you. I'm happy to take any questions.
Arnold looks like he's reconnecting his audio here momentarily. So we'll just give him a moment. There we go. Arnold, you back?
Am I on?
Yes, you are, sir. Take it away.
Okay. Somebody sent me a FaceTime call and knocked me off. Dr. Pergam.
Thanks, Dr. Oster. I think this is a fantastic presentation to review. I have two questions. Hopefully they'll be brief answers. One is in the distribution epidemiologically of myocarditis in kids. Interestingly, that 5 to 11 group is the lowest rates in general with myocarditis. Can you speculate sort of the reason why that is specifically, that's lower in the general population with standard, sort of typical myocarditis? And then number two is, I just want to be clear, you're talking about myocarditis, and then there's this sort of subgroup of pericarditis. For the discussion that you're bringing up for us, are you bringing those two together, or the reviews including both of those, or is that a separate entity in terms of how you all look at this?
Great. Okay, so first, for the epidemiology in kids, there's lots of different, theories as to why that can be. I think one of the biggest theories is that their testosterone and hormones play a big level in this, which is part of the reason why you may see a really high peak in adolescence and young adulthood, especially among males. I think people still want to learn that, and does that differ also for the different types of myocarditis? In terms of myocarditis and pericarditis, yes, both have been reported, and sometimes the symptoms and presentation, can overlap. So we tried to come up with some definition. Certainly sometimes someone will meet definition for both, and in which case we'll call them myopericarditis, inflammation of both areas. For these numbers, though, we included those who had myocarditis or myopericarditis, and not just pericarditis. But pericarditis numbers, are not nearly, they don't jump out nearly as much for the young adults. And, as a safety said, there's certainly some cases for sure, but it doesn't have the same impact in terms of numbers, nor for the long-term outcomes. But it is important to keep in mind that, that has been seen as well.
Thank you, Dr. Meisner.
Thank you, Dr. Monto, and thank you, Dr. Oster, for this presentation, because I think this is the principal concern that people have regarding use of these mRNA vaccines in children. So your presentation was very clear and it was very helpful. I would like to go back to the issue of late phase gadolinium uptake on the MRI scan. My understanding is gadolinium is very sensitive for any inflammation in the heart. But the adult cardiologists say that a late phase uptake, as you pointed out, is associated with further complications in life, or as you noted, sudden cardiac failure and death. So my question is, do we have any experience with late phase gadolinium uptake in children from other types of myocarditis, and what sort of a prognosis that affords us in terms of what might be expected? And then secondly, how in adults who have late phase uptake, how long is the interval of time before they begin to run into problems with heart failure? Thank you.
Sure. So yes, you touched upon a field that I can't even get all the cardiologists in my practice to agree on, and it's definitely a controversial field in the what is the meaning of this finding that we see? And I can tell you a couple of things about it. So first, yes, especially in adults, not so much in kids. It's been studied well in terms of its impact on longer-term outcomes. One thing, though, that people do like to see is improvement in this and resolution of this. We often see, even still a little bit of uptake, but everything else is normal. There's no active inflammation. The function's normal. Now, kids, their exercise tests can be normal. Their Holter monitor normal. Everything else can be normal, and all we have is this little, signal that you see in the MRI that's there, but comparing to prior MRIs isn't as impressive. So what do we make of all that? And I think that's an area still, ripe for investigation. In terms of progressing and progression, I will say, it's hard. I hesitate a little bit to compare everything and say what those are, because I really think of these diseases as same name, but maybe different kind of entities and mechanisms. Certainly, some of the data I showed there for longer term outcomes, adults have the higher mortality. You have acute myocarditis, whereas kids tend to bounce back a bit better. Will we continue to see that with others? Probably. I will say, I showed you the MISC outcomes. We, as a field, have all been very pleasantly surprised to see how well these MRIs have looked in the kids after MISC. So we'll see what we find after the vaccine-associated myocarditis.
Thank you.
Thank you. Dr. Rubin.
I think that was fascinating, Dr. Oster. And maybe this is a little bit of a follow-up on Dr. Meisner's question, but you were comparing classic myocarditis and its outcomes with what might be happening with vaccine-associated disease. And classic myocarditis, I know in adults, is often associated with direct viral infection of the myocardium, or rheumatologic diseases and inflammatory. What do we know from the small amount of biopsy and pathology material from the cases in children that might tell us anything about underlying mechanism and might, make us more comfortable with the predictions that you can make from the classic myocarditis case?
Yeah, I wish I could give you a good answer to that. But what I can tell you is, and I just looked at this yesterday, of those about 800 or so, 800 or 900 cases that we've called, myocarditis, I think like one or two have actually had biopsies. Biopsies not, routinely used, especially in, younger adults and in this population. So unfortunately, I can't talk about that. A number of the adults at least went to CAF to rule out a myocardial infarction, but didn't necessarily grab a biopsy, or at least if they did, it wasn't reported to CDC. So I think we don't know yet but it'll be fascinating to learn more about it.
Thank you. Dr. Carilla.
Thank you, Arnold. Yeah, Matthew, related to we seem to see the most of the myocarditis after the second dose, I'm curious about if there's been any close examination of those individuals experiencing myocarditis after their first dose of the vaccine. Do they have evidence of prior COVID infection, and specifically closely a recent COVID infection? And then related to that, do we have any data coming out of, let's say, the UK, where they've had a longer dosing they've played with a longer dosing interval between the first and the second dose? Does the dosing interval, is it the closeness of the dosing interval, the shorter dosing interval, that actually influences that rate of myocarditis that we see after the second dose?
Yeah, those are both excellent questions. For the VAERS data, we did not specifically separate out exactly the dose 1 or dose 2 yet. We didn't see, when we briefly looked, we didn't see a huge difference in any of their basic demographics. And we didn't necessarily have, we didn't feel we get good information about whether there was actually a prior COVID infection. That data is just not routinely reported to us, or is not known. As you heard earlier, large number of this population who have COVID-19 infection didn't know. Some places are starting to try to collect, for instance, nucleic acid antibody when those kids come in, and try to look at that and figure out some more. There have been some anecdotal reports of that, yes, maybe there was prior infection. Of course, that doesn't give us any information about the timing whatsoever. But I know there are some more, rigorous, robust studies that are being planned, so hopefully we can answer some of those questions. And then I think your other question was prior to how the timing. Yeah, we don't really have much information on the timing of the prior. Oh, and the UK, there has not been much released yet, but we are very interested to learn it. Most of the stuff that's come out from myocarditis that's not for the United States has been, from Israel, but also some other countries as well. But then didn't necessarily have different dosing regimens, but it will be interesting to see.
Okay,
Thank you. Dr. Gans.
Thank you very much. I really appreciated that, obviously, because I had my previous question. My question this time because you did a very nice job in answering. Thank you very much. My real question this time is this age group that we're considering right now, the younger age group, are the highest risk for MIS-C as opposed to the myocarditis. We saw that there is a drop in all the things that you explained to us. So there seems to be a very phenotypic difference between the MIS-C cardiac effects versus the post-vaccine cardiac effects, which you related mostly to the pre-COVID myocarditis. And I'm wondering, this goes to the pathophysiology question that was already asked, and what we can predict from vaccination in this particular age group. What would be their risk in terms of the cardiac effects? So I'm wondering if you could think through a little bit of that in terms of the different phenotypes of the post-vaccine myocarditis, which seems to be very different than we know MIS-C in itself has a particular phenotype. But that's what this age group is particularly high risk for, and how that could be impacted by vaccination. I think pathophys, I get we don't have data on that, and but we do have some speculation about the differences in the pathophysiology.
Yes, please. Can you speculate?
Yeah. I will try my best while staying in whatever bounds I can. So yes, you're right. We do think there are some differences, and it'll be hard, to predict what we will see here. We'll certainly be watching it closely. Regarding MIS-C, I will say, since there's some overlap in this age group, there's been over 5,000 cases of MIS-C, and CDC is certainly monitoring for all vaccine safety afterwards, and we've been something when vaccines first came out, that question that you posed was certainly of interest. And so CDC has been actively looking for, are there cases of MIS-C, that could, that are associated at all, with vaccination? What do we see? And we're not really seeing a big signal yet, at least in the 12 and older group. CDC has identified, to date, 20